Right. We're going to talk about cardiac disorders, and we're going to start with our first section here, which includes vascular and structural disorders. So our objectives here are to look at the endothelium, which we've talked about before, the cells lining the blood vessel and what their role is in regulating various processes in the body. Looking at atherosclerosis specifically, looking at aneurysms, hypertension, and coronary artery disease, including myocardial infarction. So we'll do a little review of some of those topics tonight. So here's our normal arterial structure. And just to remember that there's these various layers. So the outer layer is the adventitia. And then we have this middle smooth muscle layer, and I don't know if we always remember that that's muscle in the arteries. So when smooth muscle is affected other places in the body, it's affected in the blood vessels as well, and we'll talk about control of that a little bit. And then we have the laminal layer, and then the endothelium, which is that inner lining, and we've talked about that. We talked about that way back when we talked about inflammation and how those endothelial cells contract with inflammation and things leak out from the blood vessel into the tissue. So atherosclerosis is a process that damages that structure of the arteries, and we'll walk through what those stages are. It's really a subcategory of another disorder called arteriosclerosis. The difference between those at a clinical level is not significant for us to look at right now, but it's just a subcategory of that. Atherosclerosis is a leading cause of coronary artery disease and contributes to all kinds of coronary problems, including MI plus others. We know the risk factors for atherosclerosis, all of these lifestyle factors that influence it, as well as some things that are a little more difficult to, that you can't not choose. For example, diabetes. If you have diabetes, you can't do much to make it go away. Now, there are some things we can do to prevent it and control it and so on, but if you've got it, you've got it. Some of the other things we might be able to regulate, though. And then hyperhomocystinemia, I'm just going to mention here. Homocysteine is a normal amino acid that circulates in our bloodstream. We all have it, and there are normal levels of homocysteine, but when those levels are elevated, we see that people are at risk for heart disease, increased risk for heart disease. One of the things that lowers homocysteine levels is good nutritional intake of vitamin B12 and folate. And we're not to the place in terms of research and clinical trials to be able to say that if you have, that everybody should be increasing their B12 and folate intake. We don't have a general recommendation that people should be doing that. We're not even to the point really where if you have an elevated homocysteine level that we're going to prescribe vitamin B12 or folate for you. But we do see epidemiologically that people that have higher levels of B12 and folate have lower levels of homocysteine. So we're looking at that. There's a lot of clinical trials going on to see should we be adjusting people's levels to try to prevent or treat heart disease. Now we're seeing this in relation to heart disease, but we also see elevated homocysteine levels in relation to Alzheimer's disease. Now, there's a lot of connections between heart disease and Alzheimer's disease. It's very interesting how interrelated those two processes are. And we'll talk a little bit more about that when we get to neuro. What happens in atherosclerosis is that for some reason those endothelial cells lining the artery get damaged, injured. And all of those things that were on that last slide injure those endothelial cells, whether it's from chemicals like with smoking or increased pressure with hypertension damaging the endothelial cells, whatever it is, these things all damage those endothelial cells. And that triggers an inflammatory response so that we have those chemical mediators coming to the site and altering the normal processes that should be happening there. One of the things that gets released is these growth factors, and we talked about that when we talked about inflammation, and that the inflammatory process has as one of its steps release of growth factors that will help with healing. But in this process, it causes problems. We get proliferation of a variety of cells, and macrophages come to the area in response to this inflammatory signal, and they change the LDL that's there, low density lipoproteins that are present there, and trigger a chain of events that we'll look at on the next slide. So those oxidized LDLs are taken in by the macrophages, which causes them to be now called foam cells. The only thing that's changed about them is they've taken in this LDL, but now they have a new name. They're called foam cells. Those foam cells promote additional inflammation. And one of the things, I just want to go back to the previous slide for just a minute, that we mentioned here was oxygen radicals. And again, we talked about those early on in this course as well, and how damaging they are to structures, to cell structures. So we have continued inflammation, and then smooth muscle cells migrate into the intimal layer of the blood vessel, and we get growth of the endothelium, the endothelial cells. And that, at that stage, we call this a fatty streak. Okay? And this is just a picture that shows some of that. So here's LDL just moving as it normally would from the blood vessel into the lining of the artery, and then it gets oxidized by, and we have this monocyte here, so when it's circulating in the bloodstream it's a monocyte, and then when it moves into the tissue it's a macrophage, and it's got that LDL in it, so now it's called a foam cell. And then we have continued changes here. I like this slide because it helps us see how the progression of atherosclerosis happens. So we've just been talking about the fatty streak stage, but then things progress to intermediate lesions where we have more lipids accumulating, atheroma where that lipid accumulation continues, and you can see that the atherosclerosis is getting larger and larger and occluding more and more of the blood vessel. And then we get a fibrotic atheroma and then a complicated lesion where we have eventual plaque rupture and formation of a clot at the site. And then on this side, we see when this starts, and we begin to see these fatty streaks from the first decade of life. An early study that was done following the Vietnam War, when soldiers were killed in action, they did autopsies on them and found evidence of atherosclerosis. Now these are 18 to 22-year-olds or thereabouts, you know, so very young people, no evidence of heart disease, that when we did autopsies on them found atherosclerosis. So it's a process that begins early in life. Then as time goes on, here's the third decade, so in the 30s we're already in this stage, and then in the 40s we move into this stage. And so, yes? Uh-huh.
They said they started seeing heart disease in anywhere from 8 to 10 years old.
Yeah, so a study done in Vienna that showed early heart disease even in very young children. Yes.
Yeah.
Uh-huh. Yeah.
Actually, this is, I'm doing my research project on cardiovascular.
Uh-huh.
Not only the Vietnam, but then again during the Korean War,
Uh-huh.
they did the same thing, did autopsy opposed to 18 to 22-year-olds. Some of them had significant coronary heart disease and whether it was pneumocystis or something.
Right. Right, so, yep. Yep. So just additional studies that show this early onset of changes in the vascular space. So in this column here, we're just looking at the growth mechanism. So in this early stage, it's growth by lipid addition. So more lipids are being deposited in those blood vessels. And then as we move on, we have an increase in smooth muscle and collagen, and then formation of clots. So that's kind of the progress there. And here, this is clinically silent in these early stages. Typically, you don't see people with heart attack at that age because of this kind of process. And then as we get older, it can remain clinically silent or become overt heart disease, depending on what's happening with the patient. So as we go on here, those fibrous plaques become unstable, and we get calcification, and they start to protrude out into the blood vessel space, the lumen of the blood vessel. And then, especially during periods of exercise, we can get occlusion of blood flow as we have more demand for blood flow. And then plaque rupture, hemorrhage rupture, formation of clots there at the site with platelet aggregation, and then obstruction of the blood flow altogether. So we're looking at people's risk factors. Now this is just talking about atherosclerosis. We're not talking about MI yet, but just looking at people's risk factors, looking at vascular flow studies like carotid Doppler studies to see what the flow is through those carotid arteries, for example. Coronary angiogram to look at flow through coronary arteries. Clearly, prevention of atherosclerosis is ideal if we can get to people early on and prevent the laying down of that plaque to begin with. Looking at existing plaques and trying to stabilize them, and then tertiary, trying to restore blood flow after some event has already happened. That's the way to ride, huh? Okay, so moving on from that, I just want to talk about high blood pressure a little bit. So atherosclerosis is a big contributor to high blood pressure. If we narrow your arteries, blood does not flow as easily through them. That's going to increase the pressure. It's going to make it harder for that blood to flow through. Now, there's a group that meets on a regular basis, and they publish guidelines about high blood pressure. It's the Joint National Commission on the Detection and Treatment of High Blood Pressure or something like that. It's got a big long name, but they abbreviate it JNC. So this is the 7th set of guidelines that have come out from this group. You can access the full guidelines at that website. It's about, I don't know, 150 pages long or something. It's a great big huge thing. But here's the diagnostic criteria. So if we're looking at someone, if we want to call them normal in terms of blood pressure, their systolic blood pressure has to be less than 120 and diastolic less than 80. That means by this criteria, if your blood pressure is 120 over 80, you're not in the normal category anymore. It's got to be less than 120 and less than 80, okay? Now, the big change in this set of guidelines from the previous guidelines was the inclusion of this stage that they called pre-hypertension, because what it did was it gave a medical diagnosis to people with levels of blood pressure that had not previously been given a medical diagnosis. Okay, so we now called these people, we gave them a disease, essentially, by reclassifying their blood pressure. There was a lot of controversy about this, and does that make more money for pharmaceutical companies? Does it give people more anxiety because now they have a diagnosis that they didn't have before? Does it change their insurance rates? I mean, all kinds of questions about that. So when we change guidelines, it has huge impacts in many areas that you don't even think about. But that was one that came out of here. So now we're saying that people with a systolic blood pressure 120 to 139 or a diastolic 80 to 89 have pre-hypertension. We'll look at treatment guidelines in just a minute. One thing to think about is if people have blood pressure that falls into 2 categories, so say their systolic is 124 and their diastolic is 72, you go with the highest category, so they would still be classified as pre-hypertensive because their systolic was in the higher category over here, okay? So if somebody had 170 over 92, they would be classified as stage 2, okay? So it's the highest category of the 2. That's where they get ranked. Now, I kind of skipped this first bullet, so let's go back here. Hypertension is a sustained elevation in blood pressure, and usually we see either an increase in cardiac output or an increase in peripheral resistance. Now, I don't think I have it on here. Let me just look ahead for just a second here. I don't. Let me just give you this, because we'll talk about it later on. The equation that we look at for blood pressure is mean arterial pressure, because inside our body, what measures our pressure? The baroreceptors, right? They measure pressure. They don't measure a systolic and a diastolic. They measure the mean arterial pressure, okay? So that's what we use here. And any of you that use electronic blood pressure cuffs, the nice thing about those is they now give you the mean arterial pressure. You don't even have to figure out what it is, but it's there. So the mean arterial pressure is the cardiac output times systemic vascular resistance. And systemic vascular resistance is primarily how big or how small the arteries are. So if you have atherosclerosis, your arteries are smaller, that increases the resistance to blood flow. okay? So systemic vascular resistance, so, or peripheral resistance, same thing. So how are we going to treat blood pressure, high blood pressure? We're either going to decrease cardiac output or decrease the systemic vascular resistance, right? Because if we decrease either one of those, the blood pressure is going to go down. Okay, so that's where treatment is focused. So let's go forward here, looking at the two categories of high blood pressure that we look at, primary or essential hypertension, and that's what 90% of people with hypertension have, and what it means is we don't know what caused it. So if you think of a temperature, an elevated temperature, or fever, somebody has a fever, what do? Give them some medication to lower the temperature. Is that all you do? Yeah, you do other whatever measures to lower the temperature. Is that all you do? Try and figure out what caused it, right? And if it was caused by an infection, you give antibiotics. If it was caused by, if it was caused by anesthesia, you try and reverse that. If it was caused by being in too warm of a room, you cool down the room, right? Yes. Pain, if it caused an increased fever, yep. Could treat that. No, fever, yep. So trying to figure out what the cause of the fever is. You don't just treat the fever and then leave it, right? You try to figure out the cause. When we treat high blood pressure, we're only treating the symptom. We're not treating the cause because we don't know what the cause is. We do not know what the cause is. We know a number of mechanisms of high blood pressure. We certainly know a number of risk factors for high blood pressure, but we don't really know what the cause is. And so at this point, all we're doing is treating the symptom, trying to regulate the blood pressure without removing the cause.
So it's really a symptom. We treat it like a disease process.
Right. We call it a disease, but it's really a symptom. It's a symptom of some other mechanism that's gone wrong, and we don't really know why. Now, we're learning more about that. There's some genetic things, there's all kinds of things that play into it, but we don't really know what the actual cause is. It's not like pneumonia where you can treat the bacteria and it goes away. It's going to go on and on and on and on because we can't remove the cause because we don't know what it is.
Some things we do know the cause, like
That's secondary hypertension. Okay? So primary hypertension, which 90% of people with high blood pressure have, we don't know the cause. Sometimes we do know the cause, like pheochromocytoma, a tumor of the adrenal gland, whatever kind of pregnancy-induced hypertension. So there's all kinds of things where we can say, here's the cause. If we get rid of that, the patient will be okay. But that's only 10% of cases, and they tend to be pediatric patients. Pediatric patients tend to much more commonly have secondary hypertension than primary hypertension. And then kind of a third category, it's really a subcategory of primary hypertension, but isolated systolic hypertension, where just the systolic blood pressure is elevated. Now that's still a concern, even though the diastolic blood pressure is normal. It needs to be treated, we need to pay attention to it. It happens primarily in elderly people, and it's as their arteries stiffen, they get an elevation in their systolic blood pressure, but often not in their diastolic. So they're the people that have a blood pressure like 180/70. That would be isolated systolic hypertension. Okay. Now it would still fit into one of those categories. Yep.
So how do you treat that?
Same way.
Same way.
Yep. Mm-hmm. Yep. So we know that genes and environment play a role. Insulin resistance plays a role even in people who've not been diagnosed with diabetes. There's a connection between being resistant to insulin and also having elevated blood pressure. Insulin resistance causes vasoconstriction, which increases the systemic vascular resistance. Well, there it is, increased peripheral resistance. A dysfunction of the sympathetic nervous system, the renin-angiotensin system, some other hormones cause sodium and water retention that increase volume that also leads to increased blood pressure. And also there's some inflammatory processes going on, even in high blood pressure, something that we don't normally think of as an inflammatory disease. It's got inflammation too, and we just talked about that with atherosclerosis, if nothing else. So increased sympathetic nervous system activity increases heart rate and peripheral resistance, increases insulin resistance, causes blood vessel remodeling. The blood vessels actually change, and some of that is that atherosclerosis we just talked about, the changes that happen in the endothelial lining there. And promotion of coagulation that's going to increase the risk of a clot forming at that site. So here's just some of the things that are happening. Here's the endothelium. We see smooth muscle constriction. Here's angiotensin 1 and angiotensin 2, which are having vasoconstrictive effects on the blood vessels. Platelets coming to the site. So a norepinephrine stimulating sympathetic nervous system. So a number of chemical mechanisms happening here. Now, one of the things that's involved here is something called nitric oxide. And did we talk about that before at the very beginning? Yeah, okay. It's not the same as nitrous oxide. Yeah. So it's a free radical, but it also causes vasodilation. And so what we see in atherosclerosis is that nitric oxide is deficient. So it causes direct and indirect vasodilation. It inhibits vasoconstrictors. And then it prevents platelet aggregation and leukocyte accumulation, and also reduces some of that smooth muscle growth. But when we have atherosclerosis, we don't have as much nitric oxide released, so we have more of those things happening. Now, one of the things that's interesting is nitroglycerin, the medication, changes into nitric oxide when we administer it. So we've been using nitroglycerin for centuries and never really knew why it worked. And here's part of at least why it works, because it gets converted to nitric oxide and causes vasodilation. Well, there it is right there. And then I apparently like to talk about Viagra a lot, because here it is again. But we mentioned it before when we talked about nitric oxide, so that's how it has its action. Okay, just another picture showing here's nitric oxide in the work that it would do here.
Do we ever use the inhaled version of it? Like we use it for kids all the time.
Of nitroglycerin?
Well, we use nitric oxide. Like
Oh.
to help dilate the pulmonary vasculature, but do they ever use it systemically in adults?
I have not.
They do it to you.
Okay. So giving nitric oxide, administering it to kids commonly, and also to adults in what for what conditions?
We send people to the U for ours, but if they're in such bad respiratory failure.
Respiratory failure. Okay.
It's more for pulmonary, not so much for cardiac.
Okay. For pulmonary diseases. Okay. Good. Okay. And then the other thing that we see is all of these things that happen with high blood pressure cause a shift in our salt management. And so if we're retaining sodium, we're retaining volume, and then these other things happen as well. So all of these things add up to causing a change in our renal salt management, so we end up retaining more sodium and water. So here's the algorithm for treatment. And for everybody who is not in a normal blood pressure range, that is less than 120/80, we want to include lifestyle modifications. So what are those? Quitting smoking, sodium restriction, exercise, lose weight, all of those things can help reduce blood pressure. So we want everybody to be doing those. If they're still not at their goal blood pressure with that, and notice that the goal blood pressure here is less than 140/90. Now that's not normal, but we want them to at least be less than 140/90. And diabetics or people with chronic kidney disease, we want them to be less than 130/80. So we have a different target for them. Then we're going to look at some initial drug choices. And this is changing all the time as we're learning more about these drugs and how they work in high blood pressure. Now, compelling indications are additional risk factors or comorbidities that the patient might have. So if they have high blood pressure and they're also diabetic, we might choose a different drug than if they just have high blood pressure. Or if they have high blood pressure and asthma, we're probably not going to give them a beta blocker because that can affect their respiratory status. So compelling indications are other kinds of issues that they might have that might argue for a different drug But so if they don't have compelling indications, we're going to start them for most patients with a thiazide diuretic and may also consider some other drugs. This is angiotensin converting enzyme inhibitor, aldosterone receptor blocker, angiotensin receptor blocker. Oh, I never can remember which one that is. That's an aldosterone blocker, isn't it? Okay, so angiotensin receptor blocker, beta blocker, calcium channel blocker, or some combination. Stage 2, a 2-drug combination. So if you have stage 2 high blood pressure, you need to start with 2 medications, okay? And then with compelling indications, you're going to pick whatever drug is specific for that compelling indication. If they're still not at their goal blood pressure, you may need to add more drugs or change categories. Now the thing is most people with high blood pressure need at least 2 medications to control their blood pressure. And when you look at the statistics about the control of blood pressure, they're abysmal. Less than half of patients probably have well-controlled high blood pressure, or their blood pressure is not in good control. So we're not aggressive enough with treatment of blood pressure. Okay. So let's go on here. Let's talk about aneurysms a little bit. So an aneurysm is just an outpouching of the blood vessel wall, a weak area in the blood vessel where it kind of poofs out. And there are different kinds of aneurysms. Circumferential go all the way around. Saccular are a portion of the blood vessel, and dissecting is where it splits the arterial wall. So let's look at this. So fusiform circumferential is where it goes all the way around the lumen. Saccular is where just one part of the lumen is pouched out. So like if you had if you're looking at this marking pen, circumferential would mean that it's bulged out all the way around the artery, where a saccular might just be bulged out on one side. Okay, does that make sense? And then dissecting aneurysm is where there's a break in the layers of the blood vessel wall, and so blood can seep out in between those layers. And often what we see is that dissection then, you often hear this kind of rips down the artery. We're often talking about an aorta when we're talking about that, but it can happen in any blood vessel. And then a false one, you can see there's a leakage out, but then a clot forms there. So the things that we're concerned about are that a clot would form there and occlude the blood vessel, that it would dissect, and then the worst case, of course, would be if it ruptured. If they have a small enough aneurysm that's growing at a very slow rate, we may just watch it, depending on the patient's age and what else is going on, particularly when we're talking about aortic aneurysms. If it becomes a certain size, and you can look at the guidelines for that to find out what the size is, or if it's growing at a particular rate where it's obviously getting larger more rapidly, then we want to go in and do some kind of intervention on it. And we can do endovascular repair, which is an interventional procedure where you go in through an artery, through the femoral artery, and get into the aorta and put like a patch on it there. Or we can open you up and do an open surgical repair of that aneurysm. If it ruptures, you're probably gone. There's probably not anything we can do about it once it's ruptured, if we're talking about an aortic aneurysm. There's a aortic aneurysm with the graft put in to the aorta and into the top of the iliacs. Just a couple of other things to add here under vascular. Peripheral arterial disease. A number of causes of that. The biggest one is atherosclerosis, but Raynaud's disease is another cause of peripheral arterial disease where you have vasospasms of the arteries, and often you see that in people's hands, but it can be in any extremity. And you get vasospasm there to the extent that people can develop gangrene of the digits because they're so their blood flow is so interrupted by the vasospasm. Painful, causes discoloration of the extremities. Chronic venous insufficiency, when the blood can't return from the extremities because of whatever problem, often it's problems with the valves, where the valves become floppy and blood pools in the extremities. And whether it's from valvular incompetence or some other problem, that's when you often see venous stasis ulcers, those very difficult to treat ulcers on the lower extremities. And then deep vein thrombosis, or as they're calling it now, venous thromboembolism, VTE. The big thing there is that that's the largest source of pulmonary emboli. And so we want to work to prevent deep vein thrombosis by keeping people active and TED hose and SCDs, those kinds of things. Maybe low molecular weight heparin injections, Lovenox. And then if they develop a DVT, we want to keep them pretty much on bed rest so that that clot doesn't break off and move to their lungs. And in the meantime, put them on more anticoagulation so that the clot doesn't get any bigger until it has a chance to reabsorb back into the body.
At what point do you put like the green-filled filters in?
So a filter in the inferior vena cava. So if people have a lot of deep vein thrombosis and are throwing lots of clots into the circulation, then we might put a filter in there. And we go in and insert this little filter that's kind of like an umbrella that just sits in the blood vessel, and then obviously it's got openings through it so that the blood can continue to flow back towards the heart. But hopefully the filter is fine enough so that the clots don't go through. And it just depends on what's causing the clots and how many there are and what risk the patient's at for a serious complication from pulmonary embolism. But people that have repetitive clots, they can put a filter in there. Now, when we have the filter in the patient, then they need to be on anticoagulation as well, so that to prevent clots from clumping together and getting bigger and give the body a chance to reabsorb those clots along the way. Okay, so let's stop there and we'll take a break and come back.